Stop. Before you tell yourself to wait and see, hear this. A stroke is not a slow problem. It is a fast loss of blood flow to the brain, and minutes can change the outcome. Waiting is a decision, and delay can cost brain function. This video is education only. It does not replace medical care. If you suspect stroke in yourself or someone near you, call your local emergency number immediately and follow dispatcher instructions. Here is the key idea. In the first minutes, your goal is not to fix the stroke. You cannot remove a clot or stop bleeding at home. Your goal is to avoid the common reactions that quietly make the brain work harder while it is already under stress. People often do the wrong things for the right reasons. They try to make the person stand up. They rush them to the bathroom. They argue, shake, or demand answers. They hand over food, water, or pills. In a crisis, these actions feel helpful. Physiologically, they can raise stress, increase oxygen demand, and add new risks. A better mindset is simple. Act fast, stay calm, and let professionals take over. Your decisions before help arrives can protect time and reduce avoidable harm. You are not doing treatment. You are buying stability and protecting the brain environment until emergency care begins. In the next minute, I will show what to do and what to avoid in plain language. If you want a clear step-by-step protocol, keep watching. Now let me explain why those first minutes matter using one concept you rarely hear outside a hospital. When a stroke begins, the brain does not fail in one single block. There is usually a core zone where blood flow drops so low that tissue is severely threatened. But around that core is another zone that is still alive, just struggling. In clinical language, this is often called the ischemic penumbra. Think of it as the border area. Here is the simplest analogy. Imagine a fire. The center is burning hottest. That core is the most dangerous and the hardest to reverse. But the outer edge is not fully destroyed yet. It is heated, smoky, and fragile. If you reduce the stress on that edge, you may prevent it from catching completely. If you add stress, you can make the damage spread faster. This is not motivation. This is physiology. Neurons need oxygen and glucose, and they are extremely sensitive to drops in circulation. In the first 5 to 10 minutes, small changes in demand and stability can influence whether that border zone holds on or collapses into permanent injury. That is why panic, forced movement, and unnecessary stimulation can be harmful. They push the brain to do more work at the exact moment it has less supply. What you do before the ambulance arrives is not a cure. It is not a substitute for imaging, medication, or procedures. It is a way to protect the environment around the brain. Your job is to support calm, keep the body stable, and avoid actions that increase oxygen demand or create new risks. In the next section, I will turn this into a simple protocol you can remember under pressure. What to do first, how to position the person safely, and what not to give them, even if it feels helpful. Before we get into the step-by-step protocol, we have to solve one problem that ruins outcomes more than almost anything else. People do not call for help early because they are waiting for the classic picture. Most people know fast, face drooping, arm weakness, speech trouble, time to call. That is a helpful tool, but it can be incomplete in real life. The earliest signs can be quieter, and quiet is exactly what gets dismissed. Someone seems a little confused. They cannot follow a simple instruction. Their balance feels off. Vision suddenly looks strange in one eye. They say they feel wrong, but cannot explain it. Families often label it as fatigue, low blood sugar, stress, or just getting older. The real danger is not only the stroke itself. The real danger is delay, waiting to be sure, waiting to see if it passes, waiting for a dramatic symptom that finally feels official enough to justify calling. Every minute you wait is time the medical team cannot get back. Here is the mindset shift. Early recognition is not overreacting. It is the first and most important action a bystander can take. Not because you can diagnose the stroke at home, you cannot, but because you can protect the treatment window that modern stroke care depends on. The sooner professionals evaluate symptoms, the sooner imaging can confirm the type of stroke, and the sooner evidence-based treatment can begin. So use FAST, but do not be trapped by FAST. If the change is sudden and new, treat it as urgent. Call immediately and follow the dispatcher. In the next part, I will list the quiet warning signs clearly so you do not miss them. Here are the quiet warning signs you need to recognize. The most important word is sudden, not gradual, not something that has been building for weeks. Sudden means it appears out of nowhere and it is new for that person. First, sudden confusion. They may look present but cannot process what you are saying. They might answer with the wrong words, repeat themselves, or seem strangely disoriented. Second, sudden language problems. This can be slurred speech, trouble finding words, or speaking in a way that does not make sense. Sometimes they understand you but cannot respond clearly. Other times they speak clearly but do not understand simple questions. Third, difficulty following basic instructions. Ask them to squeeze your hand or raise an arm. If they cannot understand that request or they do something completely unrelated, treat that as a red flag. Fourth, heaviness, numbness, or weakness on one side of the body. It can be an arm, a leg, or a side of the face. It may look subtle. They may say it feels strange, clumsy, or heavy. Fifth, vision changes. Sudden blurring, double vision, or a dark curtain in one eye can happen. People often ignore this because it does not feel like a stroke, but it can be. Sixth, sudden dizziness or loss of balance. If they suddenly cannot walk straight, cannot coordinate their steps, or feel like the room is spinning, do not brush it off as just vertigo, especially if it is new and abrupt. And here is the quiet signal that matters. Many people describe a strong feeling that something is off. No dramatic pain, no obvious injury, just a clear internal sense that the body is not working normally. Do not argue with that signal. Do not wait for it to become worse so you feel more certain. If any of these changes are sudden, treat it as urgent. Call emergency services right away and follow instructions. In the next part, I will explain what not to assume, because common assumptions create dangerous delays. Now, let me remove two assumptions that cause dangerous hesitation. Many people wait because they are looking for a headache. Others wait because they think a real emergency must include chest pain. But a stroke does not need to announce itself with dramatic pain. You can have a serious neurological event with no headache at all. You can have a sudden brain circulation problem with no chest discomfort. If you use pain as your gatekeeper, you will miss the early window when rapid care can make the biggest difference. This is why those quiet signs matter so much. Sudden confusion, sudden speech change, sudden weakness on one side, a sudden vision shift in one eye, sudden loss of balance. These are not minor issues just because they are not painful. The brain can be in trouble silently. Here is the rule that keeps you safe. Do not ask, does it hurt enough to be serious? Ask, is it sudden and is it new? Sudden and new is the danger signal. People delay because uncertainty feels uncomfortable. They start bargaining. Maybe it is stress. Maybe it is dehydration. Maybe they just stood up too fast. Maybe they will feel better after a few minutes. But the cost of being wrong is high, and the cost of calling early is low. Emergency dispatchers would rather evaluate a false alarm than arrive late to a real stroke. If this section is changing the way you think, leave a comment with the number 4. Not to spam the comments, but so you remember this rule later when pressure hits. Sudden and new means act now. In the next part, we move from recognition to action. What to do the moment you call, how to stabilize the person safely, and the exact mistakes to avoid while help is on the way. So here is the moment everything becomes practical. You recognize sudden and new symptoms. You do not wait. You escalate. Step 1 is simple. Call emergency services immediately. Do not debate it with family. Do not search the internet for reassurance. Do not try to drive them yourself unless the dispatcher tells you to. When you call, say it clearly. I suspect a stroke. Then describe the sudden symptoms you saw and the exact time they started, or the last time the person was seen normal. That timeline matters because hospital treatment options depend on it. This is the part many people get wrong. They wait to be sure. They wait for the face to droop more. They wait for speech to get worse. They wait because they do not want to look dramatic. But time is not neutral in a stroke. Minutes preserved early can translate into more options later, more brain tissue protected, and better recovery potential. Now, step 2 is what you do while help is moving toward you. Stabilize, not treat. You are not diagnosing the stroke type at home. You are not deciding medications. You are creating the safest environment for the brain and the body until professionals arrive. That means you keep the person still and supported. You reduce panic. You avoid unnecessary movement and stimulation. You stay calm and speak in short sentences. Tell them help is coming. If they can answer, ask simple questions. If they cannot, do not force conversation. Everything we're about to cover next is supportive. Positioning, breathing, what not to give them. These steps matter, but they never replace the first step. Call now. In the next section, I will show the exact body position that is commonly recommended to balance circulation and pressure, and I will explain why it makes physiological sense in plain language. While the dispatcher is sending help, you need a simple protocol you can repeat under stress. Not dramatic, not heroic, just stable, safe, and consistent. First, guide the person to stop moving. If they are standing, support them and help them sit down right away. If they are on the floor, do not try to lift them to their feet. Your goal is to reduce sudden drops and spikes in blood pressure and to prevent falls. Keep your voice calm and your sentences short. Tell them help is coming. Next, set the position. Aim for the upper body to be slightly elevated, about 30 degrees. You can do this by placing pillows or folded towels behind the shoulders and upper back. Keep the head and neck in a neutral straight line. Avoid bending the neck forward or turning it sharply, because that can make breathing harder and can add unnecessary strain. Then loosen anything tight around the neck and chest, remove a tight tie, loosen a collar, and take off anything that compresses the throat. The purpose is simple. You want unobstructed breathing and you want the body to stay relaxed. Stay with them and watch for changes. If they drool, vomit, or seem unable to manage saliva, gently turn the head to the side to reduce choking risk, while keeping the body supported and the upper body elevated if possible. If the dispatcher gives different instructions, follow the dispatcher. Do not give food, drink, or pills. Do not force them to stand or walk. Do not test their strength over and over. Every extra demand is extra stress at the worst time. This positioning is not a treatment and it is not a guarantee. It is a way to avoid extremes. Flat can increase pressure. Fully upright can reduce circulation to vulnerable tissue. A moderate angle can support breathing and stability until professionals arrive. Next, I will explain why this angle makes physiological sense and how to pair it with simple breathing to reduce panic-driven strain. That 30-degree position is not random. It is a practical balance based on how pressure and circulation behave in the head. When someone lies completely flat, pressure inside the skull can rise in some situations. The brain sits in a closed space, and changes in blood volume or fluid dynamics can increase strain. On the other extreme, when someone sits fully upright, gravity can reduce the pressure that helps blood reach vulnerable brain tissue, especially if blood flow is already impaired. So the goal is not to chase a perfect angle. The goal is to avoid extremes. A modest elevation can support breathing, reduce congestion, and help you keep the person steady and safe. It is also easier for you to monitor their face, speech, and breathing without constantly repositioning them. That matters because constant movement creates stress, and stress adds oxygen demand at the worst moment. Now here is the practical adjustment that many people forget. If the person is drooling, gagging, or nauseated, you need to protect the airway. The safest approach is gentle. Keep the upper body supported, keep the head and neck aligned, and turn the head slightly to the side so saliva or vomit can drain out rather than back toward the throat. Do not force the neck into a hard twist. Small movement is enough. Your aim is to reduce choking risk while keeping the body stable. If the person becomes less responsive or breathing changes, follow the dispatcher instructions immediately. The dispatcher can guide you based on what you observe in real time. Your role is not to diagnose the cause. Your role is to keep the person safe and to prevent avoidable complications until the medical team arrives. So remember the logic. Flat can increase internal pressure, fully upright can reduce circulation pressure. A moderate elevation helps balance both, while making airway protection and monitoring easier. Next, we add the second stabilizer, breathing, not as a cure, but as a way to reduce panic-driven strain on the brain and body. Now we add the second stabilizer, breathing. In an emergency, the body does something predictable. Fear spikes, adrenaline rises, and breathing becomes fast and shallow. That reaction is normal, but during a suspected stroke, it can work against you. Shallow breathing can reduce how efficiently the lungs exchange oxygen, and rapid breathing can intensify panic. Panic then raises heart rate and blood pressure, which can add strain at the worst moment. So breathing is not just emotional, it is physiology. This is why a simple breathing pattern can help. If the person is awake and can follow you, ask them to breathe with you. Inhale through the nose for 4 seconds, then exhale slowly through the mouth for 6 seconds. Repeat. The goal is not to force deep breaths or to hyperventilate. The goal is a steady rhythm that calms the nervous system and supports more stable breathing. Keep your voice low and clear. Count out loud. 1, 2, 3, 4 on the inhale. 1, 2, 3, 4, 5, 6 on the exhale. If they struggle to follow instructions, do not argue. Do not keep testing them. Instead, you model the breathing next to them. Many people will match a calm rhythm without needing to process complex commands, especially when they feel supported. If at any point breathing becomes difficult, noisy, or irregular, do not try to correct it yourself. Tell the dispatcher exactly what you see and follow their instructions. The dispatcher can guide next steps based on the situation. One more important boundary. This breathing is not a treatment for the stroke. It does not remove a clot. It does not stop bleeding. It is supportive care. It reduces unnecessary physiological stress and helps the body stay steadier while professional help is on the way. So pair it with the position you just set. Upper body elevated, head and neck neutral, calm voice, slow breathing, stable environment. Next, I will explain the 3 simple reasons this breathing pattern can be helpful, and then we will cover the strict list of what not to do, even if it feels like common sense. Here are the 3 reasons that simple breathing pattern can matter, and I want you to keep the wording realistic. It may help. It is supportive. It is not a cure. Reason 1. Controlled breathing can improve oxygen delivery by making breathing more efficient. When people panic, breaths often become short and rapid. That can reduce effective air exchange in the lungs. Slowing the exhale and keeping a steady rhythm can support better ventilation and help the body use oxygen more effectively. Reason 2, calm breathing can reduce panic-driven spikes in heart rate and blood pressure. In a suspected stroke, you do not know the type yet. Some strokes involve a clot, others involve bleeding. You are not diagnosing that at home, but you can avoid unnecessary surges that may increase strain. A slower exhale signals the nervous system to downshift, which can help keep the whole system steadier. Reason 3, breathing influences carbon dioxide levels, and carbon dioxide affects how blood vessels behave. Very rapid breathing can lower carbon dioxide too much. A steadier pace helps avoid extreme swings. In simple terms, stable breathing supports stable circulation dynamics, which is what you want while the brain is vulnerable. Now the boundary again, because this is where misinformation starts. You are not treating the stroke. You are not fixing a blockage. You are not stopping bleeding. You are stabilizing the environment around the brain. You are reducing avoidable stress. So the penumbra, that fragile border zone, has a better chance to hold on until medical care begins. If this breathing section is useful, comment the number 9. Not to flood the comments, but because it helps you remember the pattern. 4 seconds in through the nose, 6 seconds out through the mouth, steady and calm. Next, we go to the strict do not list. These are the well-intended actions that can create serious complications even when the person looks awake. Now we need to talk about the do not list, because this is where well-intentioned help can accidentally create serious harm. Do not give food, do not give water, do not give pills. Even if the person looks awake, even if they can talk, even if they ask for a drink. A stroke can disrupt swallowing in subtle ways, and you cannot reliably test that at home. The muscles and nerves that protect the airway may not coordinate correctly. A sip of water that seems harmless can go the wrong way. Food or liquid can enter the lungs instead of the stomach, and that can lead to aspiration pneumonia, which is a serious and common complication after neurological events. In the moment, caregivers often act from comfort. They want to help, they want to fix dryness, they want to give a familiar medication, they want to do something. But in this situation, comfort behaviors can introduce a new emergency on top of the first one. Choking risk rises, breathing can worsen. The situation becomes harder for the medical team when they arrive. So keep the mouth empty. If the lips are dry, you can gently moisten the outside with a damp cloth, but do not put liquids inside the mouth unless a medical professional instructs it. If the person is drooling or vomiting, focus on airway safety by turning the head slightly to the side while maintaining the supported position you set earlier, and tell the dispatcher what you are seeing. This is not about being cold or refusing help. It is risk management. Your job is to keep the person stable and protect the airway while emergency care is on the way. Call, position, breathing, and calm monitoring. Those are your tools. Food, drink, and pills are not. Next, we will cover another common mistake: giving aspirin or other medications without knowing the stroke type, and why waiting for imaging matters before you choose anything. The next mistake happens for the same reason. People want to help fast, so they reach for the one pill they have heard about. Do not give aspirin unless emergency services specifically instruct you to do so. Here is why. Not every stroke is caused by a clot. Some strokes involve bleeding in or around the brain. At home, you cannot tell the difference. The symptoms can look similar, and guessing wrong can raise risk. Aspirin affects blood clotting. In a bleeding scenario, it can make bleeding worse. That is why the decision to give it is not a kitchen table decision. It is a medical decision that depends on evaluation and imaging. This is the boundary that protects you from misinformation. You are not choosing treatment at home. You are preserving time and stability until professionals can identify the stroke type. In the hospital, brain imaging helps clinicians confirm what is happening. That is what determines the right next step. Sometimes the safest choice is a specific medication. Sometimes it is a procedure. Sometimes it is blood pressure control. But all of that requires diagnosis, not assumptions. So when people say just give aspirin right away, that sounds simple, but it ignores uncertainty. In emergencies, simple does not always mean safe. What should you do instead? Keep the person positioned, keep breathing calm, keep the mouth empty, and keep the timeline clear. If the dispatcher asks about medications, allergies, or medical history, answer calmly. If the dispatcher instructs a specific action, follow that instruction. Otherwise, do not introduce new variables. Remember the hierarchy. Call first, stabilize second, avoid risky interventions third. That is how you protect the person and help the medical team work faster when they arrive. Next, we cover the movement trap. Forcing the person to stand, walk, or repeatedly prove strength can increase stress and risk, even when you are only trying to check if they are getting better. Now let us talk about the movement trap. This is one of the most common mistakes, and it happens because people want reassurance. They want feedback. Can you lift your arm again? Can you stand? Can you walk? Are you getting better? So they keep testing. They ask for repeated squeezes. They ask the person to take a few steps. They try to get him to the bathroom, or they say something like, "Walk it off, you just need to move." That mindset is dangerous in a suspected stroke. A stroke is not a muscle problem. It is a brain circulation problem. When the brain is under stress, forcing movement can increase oxygen demand and raise physiological strain. It can also increase the risk of a fall, which adds trauma on top of a neurological emergency. And repeated stimulation can increase panic, which pushes heart rate and blood pressure higher, exactly what you want to avoid while you are waiting for professionals. You do need some information, but you do not need a constant drill. The most valuable information is the timeline and the sudden change. When did symptoms start? What changed suddenly? What was the last known normal time? That is what helps emergency teams make decisions. Testing strength again and again does not create new treatment options. It mostly creates stress. So choose stability over constant checking. Keep them seated or supported in the position you set. Keep the environment quiet. Speak in short phrases. If they try to stand, gently discourage it. If they insist on moving because they feel embarrassed, remind them that this is not a pride test. It is a safety decision. If you need to communicate status to the dispatcher, focus on what you can observe without forcing anything. Speech changes, facial droop, one-sided weakness, level of alertness, breathing pattern, and whether symptoms are getting worse. Next, we will connect this back to treatment windows and why the single best help you can provide is speed, clarity, and a stable environment until care begins. Everything you have heard so far points to one reality. Modern stroke care is time dependent. In many regions, there are treatments that can reduce disability for certain types of stroke, but they must be started within a specific window. One commonly discussed example is clot-busting medication for ischemic stroke, which is often described as being most effective when given within a few hours of symptom onset, sometimes cited around 3 to 4.5 hours, depending on clinical criteria. In selected cases, mechanical clot removal may be considered later, but those decisions depend on imaging, severity, and how much salvageable tissue remains. The exact numbers can vary by country, hospital protocols, and the patient situation. That is why the safest principle is not memorizing a time limit. The safest principle is calling immediately, because the clock starts the moment symptoms begin, or the last known normal time is established. This is where systems thinking matters. Your early actions shape later options. If you wait at home, the medical team loses time they cannot recover. If you drive around searching for the right clinic, you lose time and may delay imaging. If you keep the person walking and testing and drinking water, you add stress and risk. But if you call fast, state that you suspect a stroke, and provide a clear timeline, you help the system work. If you position the person safely, keep breathing calm, avoid food and pills, and reduce panic, you buy stability. That does not treat the stroke, but it can protect the brain environment and reduce avoidable complications. So think of your role like this. You are not the surgeon, you are not the scanner, you are the first link in the chain that brings the right help to the right person at the right time. In the final section, I will zoom out. Why age and vascular health change the risk and what long-term prevention looks like after the emergency is over. Now let us close the loop and zoom out. A stroke is a moment, but risk is built over years. As we age, blood vessels can become less flexible, reserves can shrink, and inflammation and metabolic strain can rise. That does not mean recovery is impossible. It means the margin for delay can be smaller, especially in older adults. So speed matters more, not less. If you remember only one lesson from this video, make it this. In a suspected stroke, waiting is not neutral. Your job is not to treat the stroke at home. Your job is to act fast, protect the timeline, and avoid the mistakes that add stress and risk. Call emergency services immediately. State that you suspect a stroke. Share the exact start time or last known normal time. Then stabilize. Upper body slightly elevated, head and neck neutral, calm breathing if they can follow. No food, no drink, no pills unless the dispatcher instructs it. no forcing movement, no walking it off. Those steps do not guarantee an outcome, but they reduce avoidable harm and preserve options for the medical team. After the emergency, the real work begins. Recovery is often a structured process that can involve physical therapy, occupational therapy, and speech therapy, guided by clinicians. Progress is usually built through consistent rehabilitation, not quick hacks, and long-term prevention is upstream. Vascular health, blood pressure control, diabetes management, sleep, activity, and inflammation all shape the environment where the brain heals and adapts. Neuroplasticity is real, but it works best when the body has stable support. So take this video as both a crisis protocol and a life lesson. Prepare for the rare event and build habits that reduce the risk in the first place. If you want, comment one takeaway you will remember under pressure, even a single sentence. That helps other viewers learn, and it helps you lock the protocol into memory.